In this session at Digestive Diseases Week 2012, we talked about patients with constipation-related symptoms. And we talked about patients that have classic chronic constipation and also patients with the irritable bowel syndrome and constipation. The major distinction of which is that patients with IBS-C have a significant degree of abdominal pain or discomfort. For patients with constipation-related complaints, if they have mild and frequent complaints, we oftentimes will recommend dietary and lifestyle recommendations. So specifically, increasing the amount of exercise, which has been shown to have benefits in terms of increasing or accelerating colon transit, and also increasing dietary fiber, which can have benefits for some patients' mild and frequent constipation-related symptoms. If people have more severe or more frequent constipation-related symptoms, oftentimes they'll require laxative therapy, and there are a variety of different types of laxatives which have been shown to be effective in clinical trials. So things like osmotic laxatives, such as polyethylene glycol, there's excellent data to suggest that this particular type of laxative improves stool frequency as well as stool consistency. It's not as clear that osmotic laxatives like polyethylene glycol improve abdominal pain in patients with irritable bowel syndrome. There are also a group of drugs that affect chloride secretion in the intestine. Drugs like lubiprostone, which affects chloride secretion through the CLC2 channel and improves constipation-related complaints, as well as abdominal pain in patients with IBS. Newer drugs that affect chloride secretion include linaclotide and plecanatide. Linaclotide and plecanatide are actually drugs that activate the GCC receptor on the intestinal cell, the enterocyte, which leads to an increased production of cyclic GMP, which then opens CFTR, an important chloride channel in the intestine. That again improves constipation-related complaints. And one additional aspect of this group of drugs that's potentially very important for these patients, especially patients with IBS that have abdominal pain, is that cyclic GMP extracellularly may reduce firing of visceral afferent neurons responsible for the sensing of abdominal pain. A really important thing to realize is that patients that don't respond to dietary lifestyle recommendations and laxatives therapies may have something called dysenergic defecation. That's the inability to coordinate the series of events that lead to the normal passage of stool from the rectum. Now, dysenergic defecation can be detected by a routine digital rectal examination. In other words, on digital rectal examination, a physician can evaluate for relaxation of the puborectalis muscle, the anal sphincter, and contraction of the abdominal wall muscles, all of which need to happen for people to be able to normally pass stool from the rectum. Why is dysenergic defecation important? It's important because patients that have this uncoordinated defecation don't get better with laxative therapy. So therefore, if you identify these patients, you can recommend that they undergo biofeedback training and improve their constipation-related complaints. So the key points, I think, there are a variety of exercise can be beneficial. Increasing fiber can be beneficial for patients with mild infrequent symptoms. Laxative therapies can be helpful, things like osmotic laxatives, stimulant laxatives, which I failed to mention a moment ago. There are now randomized controlled trials suggesting that bisacodyl or sodium picosulfate, another stimulant laxative, can both be beneficial for constipation. Chloride channel drugs, which are coming down the pipe, and also lubiprostone is available in the United States at present. And in patients that don't respond to laxatives, thinking about dysenergic defecation. Hopefully those tips were helpful for you, and I'm sorry that you missed Digestive Diseases Week 2012.